Welcome back. We're actually going to start out talking about renal cell cancer with Dr. Jonasch and Rini, and we have Mayan Hussein from the Florida Cancer Specialist. We're going to start out talking about renal cell cancer, and I guess before we're going to take a look at some data, but also we wanted to allow Mayan to sort of bring up some questions based on his own practice. And maybe we could just start out with a couple of questions from Mayan in terms of patients really with just renal masses. Mayan, what are some of your questions here?
You know, we get those consults where a patient gets in an accident or get an X-ray or CAT scan for a different reason, and then they found this incidental renal mass. And I usually refer those to urologists, and then some of the times I notice that they do nothing about it. So my question is, when is a renal mass is important to deal with? We have that myth that, you know, if you do a biopsy, you can see it, but my RR friends say, no, we can do a good biopsy and not see it. So should I just listen to the urologist and just go with surveillance? Should I biopsy this? I mean, and that's, I think.
Brian, any thoughts?
Sure. So there's a large body of literature about the small renal mass, 4 centimeters or less. My recollection is that those series have shown a growth rate of 3 millimeters a year collectively. We will often biopsy up front, which I think is safe, because if you get high grade, if you get sarcomatoid, if you get some features that might push you to do something, you know, depending on age and comorbid status of the patient. And obviously gives you a diagnosis, make sure it's not a met or something else. So I would say we commonly biopsy and we commonly watch these folks. I don't know if I know my urologist's exact scan schedule, but they probably do a CT scan at 6 months and then maybe annually, but generally there's no rush. And we talk about these patients a lot in tumor board, and it's usually the patient who has prostate cancer and then an incidental renal mass or something. Right. So I guess I would listen to your urologist and your interventionalists who say they can do it safely. I believe that.
So Eric, Mayan was also telling me, we have a little joke when we do webinars where we have a bet how long it's going to take before somebody asks about ctDNA. But Mayan, you had mentioned to me you want to bring this up to them, so maybe Eric can deal.
I mean, it's becoming like I guess now the soup of the day or something. So now, do you use that, and can you use that for instance in? I guess you need a biopsy first, like if you want to do ctDNA if you didn't get a biopsy. But after you get a biopsy, is that something that maybe you can use to see instead of scans?
Particularly in the adjuvant situation.
And also,
Yeah, the sensitivity, you know, there clearly are data out there showing that there may be some utility using ctDNA, like, you know, the Natera-based platform. But in the non-metastatic setting, and even in the metastatic setting, we really don't have validation of that. And the other thing is that the shed rate in renal cell carcinoma is relatively low. So I would not use that modality as a means to follow. I mean, things that are coming down the pipeline, it's not ctDNA, but like imaging. I mean, there's now CA9 PET imaging that might be useful in determining whether or not what you're seeing on that CT scan, it has clear cell features or is clear cell renal cell carcinoma or not, because if it's got CA9 expression, you can use PET. But right now, I would say ctDNA is not validated.
So even in early stage, because, you know, with the PET scan, sometimes they don't recommend because, you know, they get excreted through the kidney, so you always have that light there, but you can use that PET in early stages?
So it's a specific PET, right? So it's a CA9, carbonic anhydrase 9 PET that does actually provide, can be informative. But, you know, I think there's a mixture of things you can use here. So MRI characteristics, sort of differentiating between a quote-unquote clear cell versus non-clear cell versus other variants. Combination of CT plus MRI plus these imaging modalities can be helpful. But, you know, back to what Brian said, you know, a lot of times the urologists will biopsy just to provide information of what you're dealing with, and that's still, it's A, safe, and B, still a gold standard.
So Brian and Eric, you know, we've had this sort of running theme throughout this meeting that we want to try to ask you questions as Mayan just did. We've had sort of a humorous approach to it that we've been doing through the meeting. Here's the GU version of it.
Yeah, that's a great question, Neil.
Well, it is a good question.
What a great question.
That's a great question.
That's a great question, and one I think that we face often.
That's a great question, Neil. I'm so glad you asked me that.
That's a good question, Neil.
Yeah, that's a great question. I mean, this is a challenge.
It's a great question.
So very good question.
That's a great question, Neil.
It's a great question.
It's a great question.
Yeah, and these are great questions.
So yeah, just that's the whole idea, is try to ask you something that will challenge you. So we're going to talk first about talk about questions. Probably the number one question: first-line therapy of metastatic disease, but many other that we're going to try to tackle during this session. And before we get into that, and Brian, you're going to talk about the data, but can you guys just sort of clinically go through? We have a bunch of fellows here, as well as people new to oncology, how clinically you think through first-line therapy and metastatic disease, how your risk evaluation ties into that, and how the symptomatic status of the patient affects what you do.
Okay, that's a great question. That's a lot. So when I'm approaching a frontline metastatic patient, I think there's a number of questions. If they have their primary in place, then there's a question about debulking nephrectomy, which is a whole can of worms we can go into. You might think about observing patients. There's probably a good 5 or 10% who have very indolent disease. They had a nephrectomy 12 years ago. They got little lung nodule 2 years ago, and they're finally growing. So there is a role for sort of observation, even with the drugs that I'll talk about in a second. And then I think local approaches like SBRT have really blossomed in the last, decade or so. So again, 2 or 3 lung nodules that are growing, you might do SBRT in an attempt to at least defer systemic therapy. These aren't studied in randomized trials, but I think most experts sort of use this pretty liberally in their practice. So that's all pre-systemic therapy, right, to think about. Once you decide the patient needs systemic therapy, I have one slide on IMDC, which is good for prognostic, but not very good for predictive. So I might note it in my note, but I'm not really using it to make decisions. And I'll talk a little bit about how I decision make in frontline kidney cancer, but the IO-TKI regimens have more tumor shrinking ability and less early progression, so that bulky symptomatic patient probably needs an IO-TKI, pick your favorite. Ipi-Nivo, I think, is characterized by more upfront toxicity, but probably greater durability of response. So I use that in the younger, healthier sarcomatoid patient. But as I'll talk about, we have 4 regimens that have extended survival, and it's really just a matter of becoming familiar with that regimen and using it wisely.
I was just flashing on the fact, we've been showing these videos of people saying that out of humor, but I was just thinking about the fact that these are all from the last year. And it's just so amazing, our ability now to talk to each other. It's just, from our point of view, it's just incredible to be able to talk to so many people. So Eric, again, the idea of, just pick one and use it, but I am curious how you individually decide on what TKI-IO combination to use. Do you have a favorite?
Yeah, in my practice, we're frequently using cabozantinib and nivolumab off study, mainly because of the fact that, it's an interesting thing when you looked at the pembrolizumab lenvatinib study versus the cabozantinib nivolumab study, there was a decision made to go with a slightly lower dose of cabozantinib than the monotherapy dose, 40 versus 60. And that's resulted in sort of a general manageability of that regimen where dose reductions manage the toxicity, and that ends up being a little bit easier. And so because, as Brian said, you use something, you get used to it. This is one of our go-to regimens in our clinic. Does that mean that any of the others are wrong to use? Absolutely not. But I think you need to get familiarity with the regimen, you need to know what its warts are, and then use it wisely.
So on my end, I know when we chatted, we brought up the issue, briefly alluded to, of cytoreductive surgery. You mentioned you wanted to bring that up.
Yeah, so I don't know if you guys remember the movie Independence Day, where to defeat the aliens, they have to kill the mothership. So, does that work in metastatic renal? Like if you take the kidney out, what do you think? I know with interferon there's some data, but do you think with the new agents we have, is that something that can help with when you reduce the burden?
Yeah, it is a really complicated topic. I'm a believer still in debulking nephrectomy, as you say. There's old data, it's beneficial. There's more modern data, the Carmine trial, that used sunitinib, so modern in that sense, that didn't really show a benefit. But it's always been all about patient selection. So I say if I walk in tomorrow at 54 with a 16-centimeter primary and small volume lung disease, take my kidney out, right? If it's my 85-year-old father with liver mets and bone mets and a brain met, of course not.
Yeah.
Right. So there's sort of the extremes which are obvious, and then there's the more difficult gray area. And I think it just has to do with, is the primary symptomatic? Does it represent the vast majority of the total tumor burden, i.e. 90 or 95%? Can you get that patient to and through a surgery quickly? right? A lot of times I'll see patients, they've already seen my urologist, they're scheduled for nephrectomy next week, right? So it makes it an easier decision, but I think it's very personal. I think we could get 10 experts up here and debate all day about whether to do it or not, but I think it really comes down to patient selection. So I think it should be considered, but it's not for everyone, and there are emerging data about putting it off and doing consolidative nephrectomy later. No randomized trials yet, but that's also an
So would you do treatment first and then see what happens, or depends on again?
Depends. Yeah, no, I'm not giving you a great answer.
How
but-
aggressive your urologist is, maybe.
What's that?
How aggressive your urologist in getting the patient?
Yeah,
in?
I mean, generally, if I send the patient, they'll do a nephrectomy. So
Yeah,
I view
no
myself
harm
as the
with it, yeah.
decision maker there. But I think there's nothing wrong with giving drugs first and delayed nephrectomy. The problem is some patients may not make it there. When you delay nephrectomy, you have to take them off drugs for a while, and they can have other progression. So it's not an easy decision to everyone. Oh, we'll just delay and take you later. That doesn't happen all the time.
So another issue that's come up, Eric, as we talk about checkpoint inhibitors, and I want to bring it up here as well, is the issue of relative contraindications, prior history of transplant, autoimmune disease. In the metastatic situation, how do you think through that in deciding whether or not to use an IO?
Yeah, the number of patients that are out there where there's absolute contraindications to IO, I think is getting less and less as we become more and more experienced. Taking that extreme example, actually, of an individual who's had a solid organ transplant, there is a small body of literature out there now that shows that it's probably okay to use an IO agent from a toxicity and from an organ rejection perspective. Whether the efficacy is there is a little more controversial, but I would say even in that extreme situation, I think if you don't have other choices and the patient's disease burden is so worrisome, you can even do that. If I have a patient who's got very active rheumatoid arthritis or very active lupus on biologic agents, I don't think that's a person that I would want to start on IO therapy. I've also had individuals, for example, with very aggressive psoriasis where we've tried this and it's really made things much more challenging. So I'd say short of that extreme example in the individuals who have rheumatologic or autoimmune diseases, you could probably dip your toes in the water, try it, and if you do run into trouble, you can always stop using it.
All right, well, let's take a look at some data. And Brian, you pulled together some slides looking at frontline therapy and refractory disease.
Yeah, thanks, Neil. So I'm going to go, pretty quickly sort of through the landscape of treatment for clear cell kidney cancer. These are my disclosures. So a quick case first. So this is a 72-year-old male presented with a renal mass. I guess that's almost 5 years ago. Had a nephrectomy. It was clear cell kidney cancer. There was no adjuvant therapy at the time, so it was just observed. Unfortunately, a couple of years later, developed some metastatic disease. Actually was observed a little bit even with the development of metastatic disease, and then started axi-pembro in the fall of 21. Well tolerated, had a PR on their CT scan at 3 months, was on for a while, and then you see in March of 22 had progression, which unfortunately is the outcome for most of these patients. I think there is a fraction of patients who are cured with frontline therapy. I'm not sure we know what the number is, but unfortunately this patient progressed. I commonly use cabozantinib second line if it's not used frontline. As Eric mentioned, this patient got cabo monotherapy for 8 months, then unfortunately progressed further. Still doing well, reasonably fit, ECOG performance status 1 with the symptoms you see there, mild anemia, and other labs normal. This is a very typical refractory kidney cancer patient in my clinic, and I think I'm going to talk about frontline first, but then I'll come back to the treatment options for this patient.
Before you continue, just kind of curious how the patient did with the axi-pembro. What are the usual tolerabilities you see with that doublet, and how does that compare to the other two commonly used doublets?
Yeah, I mean, I'm biased towards axi-pembro, having been involved with this development, but I think it's probably the best tolerated regimen, and Eric mentioned the difference in TKI dosing among the IO-TKI regimens that really drives the tolerability. It's not the IO component generally, it's the TKI component. So axi is dosed at 5 BID and goes up or down. Cabo is 40 and cabo-nivo is sort of a middle dose, and lenvatinib is 20 milligrams in len-pembro, which is a high dose. So I think some of the tox and perhaps efficacy differences we see among those three are TKI dosing related. Common side effects, fatigue, diarrhea, hypertension. Axi causes hypertension almost everybody, much like tivozanib I'll talk about later because of its sort of potent and selective VEGF targeting. But and I'm very quick to modify TKI dose. I give breaks on TKI. There's nothing that says these patients have to take pills every day. So So I'm a very liberal interrupter of TKI. Take 3 days off here or there, it really recharges their batteries. And you have to sort of talk patients into it. And usually you can elicit their spouse to help talk them into it because their spouse is dealing with the side effects as well, of course. But then once they do, they're like, oh gosh, doc, that was great. So I use that to make these regimens more tolerable. All right, I mentioned IMDC prognostic criteria. This is from Danny Hang's original 2009, so 15-year ago publication. And you see and are probably familiar with the 6 clinical factors that make up this scoring system, which predominates in kidney cancer. Now there's 2 clinical and the 4 laboratory you see there. And then patients are divided into favorable, intermediate, or poor based on the number of risk factors that's on the bottom. And then I put basically my interpretation. So if a patient is favorable risk, they're either inherently slow growing, right? Kidney cancer has this very diverse biology. They're either on the more indolent side of that or they're very VEGF responsive. Remember, these criteria were derived from patients who received VEGF monotherapy, largely sunitinib. So by definition, patients who did well long-term, i.e. favorable, that top blue line, had to have been responsive to VEGF agents. So it's not surprising that we see a greater effect, say, in favorable risk patients to the IO-TKIs, right? Because they have an anti-VEGF component to them. This is sort of a different way of looking at the biology. This is some RNA-seq data from the Bev-Atezo study, which I won't talk about because it was never submitted for registration. But it broke patients down by their baseline tumor samples into 7 biologic buckets or clusters. And it really, the point is not really to go into the biology of this slide, but just to show that the main drivers of kidney cancer are angiogenesis and inflammatory pathways. So not surprisingly, the drugs we use are anti-angiogenic and inflammatory, if you will, with the PD-1 inhibitors. All right, this is a summary slide that I believe is updated as of ASCO GU this year, so this is the most recent data. And because I don't have time going to each slide individually, and the data is now 5+ years old really for all these trials, I just point out some sort of high-level points across trials. So one is there's a pretty consistent overall survival benefit, right, basically in the 0.7 range. The IO-TKIs have fluctuated a little bit. Ipi/Nivo has been very consistent, but if you're looking at the value of these in terms of a survival benefit against sunitinib monotherapy, it's pretty consistent, which is why I think most experts will say, that they're relatively interchangeable. It's not that one is better than the other. They all have consistent effects, although there's nuances. If you look at the PFS, the response rate, and the primary PD at the bottom, there's more tumor shrinkage, right? So when you have 2 different mechanisms, when you have a VEGF agent in your doublet, you shrink more tumors and less tumors progress early. That may be more or less important to you as a provider or to the patient, right? As I mentioned, a patient with bulkier disease or more symptomatic, that would be more important. A patient with small volume lung disease, that would be less important, of course. And again, that's where you sort of get into the nuances of choosing one versus the other. I mentioned that less early PD with the TKI-containing regimens in the range of 5-ish% as opposed to about 20% with Ipi/Nivo. And then Ipi/Nivo, obviously distinguished by its anti-CTLA-4 agent. I don't have the data on here, but I think the tail of the curve is probably higher. The tail of the PFS curve is more like 25% as opposed to maybe 18 to 20% with the VEGF TKI. And the responses are definitely more durable. The durability of response is over 50% with Ipi/Nivo. So it's, if you will, an investment up front of toxicity for a chance of durability. Some patients want that, can tolerate it, and can afford that, and others can't. I tend to use Len/Pembro because of its high tumor shrinkage. I totally agree with Eric, though it's a difficult regimen to give, and Cabo/Nivo and Axi/Pembro are fine. I tend to give Axi/Pembro if I have a more frail patient who I just don't think will tolerate the Len/Pembro combination, and I tend to use Ipi/Nivo in younger, healthier patients with lower volume disease. And I don't think I have a slide on it, but any sarcomatoid component is uniquely sensitive to Ipi/Nivo. Those CR rates are in the 25% in that sarcomatoid subset. Okay, I do have that slide. So this is subset data from Checkmate 214 that we looked at now a couple years ago, and it's basically, I think, 125 patients who had central pathology review of their baseline tumor samples, and that's important because there's a lot of variability in what's called sarcomatoid. But central path review, and you could see it was about 75 patients per arm, and the OS on the left, PFS on the right. Any patient with sarcomatoid histology did extremely well on Ipi/Nivo, and they tend to do poorly on TKI monotherapy, as those bottom curves would show you. And you see on the bottom there, OR of 61%, which is in the range of IO-TKIs, and a CR rate of 23%. And I think this is relatively consistent. I think most experts would agree that in patients with sarcomatoid histology, they should get ipi-nivo. Maybe not everybody, but I think there's a general consensus.
What do you see in terms of PD-1 or TMB with sarcomatoid, and any sort of pathophysiology that explains why it's more sensitive?
Yeah, most sarcomatoid patients will be PD-L1 positive, but not all. And PD-L1 definitely enriches for ipi-nivo response. The data was actually presented way back when in the initial presentation and doesn't really get talked about much, but those are not entirely overlapping, but they're largely overlapping, but not TMB. TMB hasn't really borne out in kidney cancer as a marker.
Eric, any thoughts about why sarcomatoid responds so well?
It's a very inflammatory microenvironment, so you're going to see that, back to why is PD-L1 upregulated? It's because you have a whole bunch of interferon gamma secreting T cells that are charging into the microenvironment. You're getting thwarted by the upregulation of PD-L1. So you basically have this locked and loaded immune system that then blocking PD-1 signaling, they're able to actually engage.
Interesting. Please continue.
Thank you. So there was some data at ASCO GU this year I'll talk about briefly. It was subcutaneous Nivo versus intravenous Nivo. Sabi George, who's at Roswell, one of my former fellows, presented these data. You see a smallish, about 250 patient randomized trial. This is nivolumab in a refractory setting, so not really how we use the drug now. Again, it was meant to look at the pharmacokinetics and pharmacodynamics to see if subcutaneous dosing would be an option, which quite obviously can have advantages in terms of chair time and infusion time and in developing countries, et cetera. So there could be a lot of advantages to subcutaneous administration. Primary endpoint, the co-primary were the PK non-inferiority that you see in the rows here on the left, subcutaneous in blue and the Nivo IV, and then you can basically see non-inferiority of these endpoints. So again, enough patients to show that, and there's actually higher exposure, higher PK, higher exposure with the subcutaneous as opposed to the intravenous. And then if you just look at some gross clinical outcome, obviously you want to make sure that the clinical effect of these two formulations are the same. You see overlapping PFS curves and similar overall response rates, if anything, a higher response rate for sub-Q, maybe because there's higher exposure, but I wouldn't read too much into that. I think this was taken appropriately as no difference or non-inferiority for the clinical endpoints in this study. So then moving on for the rest of this to the refractory setting. This is actually an old slide because all these data were after VEGF TKI. So when VEGF TKI monotherapy was the standard of care, that's when these agents were developed. But it gives you a sense of what's been out there, and then I'll talk about some new developments. I won't read this to you, but if you look at that overall response rate, about 20% is about the default response rate in refractory kidney cancer. Progression-free survival in, call it, the 5 to 7 month range. Lenvatinib everolimus on the right stands out, but remember it's a phase 2 trial, not a phase 3. So we're a bit comparing apples and oranges here, right? Data always gets worse when you go from phase 3 to phase 2 generally, but that regimen does stand out, although there's a fair amount of toxicity that you see on the bottom. And up until recently, it's a bit of dealer's choice, right? I like this drug better because it has less toxicity. Nivolumab, again, now used up front, generally with Cabo-Nivo. Lenvatinib everolimus, more toxic, but used in a refractory setting. So we have a number of options in the refractory setting. None of them are great. Let's just start there, right? None of them are curing patients, and they all have their faults, but there are a number of options. The most important data in the refractory setting that came out, I think, in the last year was this CONTACT-03 study. So a lingering question had been, gee, everybody's pretty much getting immune-based therapy up front. Can they get immune-based therapy with benefit in the refractory setting? So this is one of two studies, the first to be reported, which randomized patients who had IO refractory kidney cancer to either Cabo-Atezo being a PD-L1 inhibitor, or Cabo monotherapy that I mentioned as a standard of care in this setting, looking at PFS. And it was completely negative. This is just a composite slide I put together. You don't need a statistician to see that those PFS curves are overlapping. Response rates in the 40%, which is actually pretty good for Cabo monotherapy, and a PFS in the 12-month range, or 10-month range, which is really good for Cabo mono in that setting. We can hypothesize about why Cabo mono did so well in this setting. I think there's probably some lingering PD-1 effect. When you stop prior PD-1, it doesn't go away the next day, right? There's lingering drug and probably lingering T cells and some other reasons we can go into. And importantly, not surprisingly, there was more toxicity with combination, including patient deaths. I think these data are very important because this was happening in practice. I see patients who failed IO-TKI and then they're put on another IO-TKI, and you should not be doing that. There's absolutely no data to support it, and it leads to toxicity, including death. There's another study called TiNivo-2, which I don't have a slide of, which is tivozanib nivolumab versus tivozanib, which will add to these data. I think most people think it's probably going to be negative. We should know in the next year or so. But again, it's important negative data. So sequential immune therapy is not a thing in kidney cancer until and unless we get different drugs, different trials, different mechanisms.
Can we just go back to the Lenvima everolimus? Because I do have a patient actually who's been doing great on this regimen for almost
On which?
like 3
On everolimus. Is that what you said?
Everolimus lenvatinib, regimen. So would you save that for? And he had like 2 previous lines of therapy, like had immune, VEGF, then Cabo, and that was his kind of 3rd line. He still gets like some oligo meds here and there that we zap or radiate. But I mean, as long as you manage his side effects, which I agree with you, it's a lot, but
How long has he been on treatment?
almost 2 years to and
Wow.
change, yeah. And he travels. He's like good performance status.
You seen that before, Brian?
I mean, I don't use a lot of the regimen because it's really toxic, and I think we have other options. But I have used it, and again, with dose reduction, certainly you can get people. There's no question it's active. Philosophically, when I'm approaching the refractory patient, they're not curable. Right. So I'm going for disease control with the lowest amount of toxicity.
And quality of life, yeah.
And quality of life. And I think I can do that with other regimens, but great.
Yeah.
Right? Good
How
for
about
that patient.
tacrolimus? Is that, I mean, so far those like, is that like out of the picture now?
Yeah.
Okay.
Do you mean just everolimus monotherapy?
No, tacrolimus,
Tacrolimus?
yeah.
No, I haven't used that.
Yeah. And for the immunotherapy, if you have someone who's doing well on immunotherapy, would you stop at 2 years?
So good question. All the trials that I showed for IO-TKI stopped
I thought we agreed on great question. We're not accepting that
Oh, great question. Sorry. It's the best question I've had.
See?
All the IO-TKI trials stopped IO at 2 years, and that's a holdover from the melanoma days, completely arbitrary. I do stop at 2 years. We looked in 426, we've looked at what we call the completer analysis, the 25% of patients who did stop at 2 years. And it doesn't appear that they're falling off and progressing and bad things are happening.
Yeah.
Again, it's a subset, it's retrospective, there's a lot of caveats to that. I think the more fundamental question that is unanswered and we have no data for is, can you also stop the TKI?
Yeah, right.
I do it anecdotally. I talk with the patient. I'd be interested in what Eric does. I have some patients who stop and some who don't want to stop, and so but there's no data in that regard. But I do stop at 2 years.
Eric?
I don't. And it's because of the fact that you have a lingering, as you pointed out with these second line studies, there's a lingering effect of PD-1. And so we don't know whether or not this PD-1 blockade is necessary. And we do see that the curves start dropping off in the IO-TKI regimens after multiple years. And the difference between Ipi-Nivo is that the Nivo is continued and those people weren't stopped. So I think we don't know. I absolutely agree with you, Brian, that from a data-driven perspective, that's what was done in the trials and that's what you should do. But I'm just have a lingering suspicion that maybe that wasn't the right choice in these trials.
Anyhow, I want to hear about belzutifan, so keep going.
Okay. All right, you're going to hear about tivozanib first. This is TiVo-3, large study of Tivo versus sorafenib, old standard of care in a refractory setting. Tivo has this interesting regulatory history. They did Tivo-1, which was this study in the front line. It had all sorts of problems we can talk about, and so this was sort of to salvage its use in kidney cancer. What it showed was a progression-free survival advantage, and again, you see a PFS in the 5-ish month range. Response rate was about 20%. Interesting, you see a bit of a tail of the curve here, which you don't usually see with TKI monotherapy. The advantage to tivozanib, maybe I have it on the next slide, is its tolerability. So like axitinib, it's a very potent and selective VEGF inhibitor. Hypertension being the biggest side effect, but I use a lot of this drug in the 3rd, 4th line setting. It's 3 weeks on, 1 week off as well, which gives patients a break, which I like. And again, it's not that it has incredible robust efficacy versus other agents. I think it's in line with that other table that I showed you. But again, I value tolerability in that refractory setting because I know I'm not curing patients. Anyway, this was the registration. Drug was approved maybe a couple years ago now, almost 3 years ago. This was the registration trial I mentioned. There's that combination with nivolumab trial going on that we should have in the next year. And then lastly, just to talk about belzutifan, the newest kid on the block, and Eric was integral in its development in VHL and otherwise. But the biology of kidney cancer, as you know, is VHL inactivation. hypoxia-inducible factor or HIF accumulation, and then driving VEGF and many other downstream targets of HIF. Belzutifan is a first-in-class HIF transcription factor inhibitor. It was first approved based on Eric's study in VHL syndrome patients. I can't remember if I have slides, but it is absolutely transformative in that disease. And then the study I'm going to talk about, which is called 005, just reported at ESMO, looked at it as monotherapy in a refractory setting, but very rationally designed for the disease biology of kidney cancer. So here's I think I have one slide in VHL syndrome. This is my favorite one. If you've taken care of any of these patients, they get multiple procedures on their kidneys for kidney tumors, on their brain and spinal cord for CNS hemangioblastomas. To the left of that, time zero are all the blue dots for the procedures for these patients, and to the right, and this isn't even the most updated, you see there's very few blue dots to the right of that vertical line at zero. So it's dramatic. It has dramatic effect because all of these patients' tumors are VHL driven by definition, right? In sporadic or non-inherited kidney cancer, a large fraction are, but not 100%. And that probably accounts for some of the efficacy differences. So this LIGHTSPARK 05 just reported at ESMO was the registration intent trial for belzutifan monotherapy. There have been previous single-arm studies that showed response rates in the 20% and very well-tolerated drug, even better than any of the TKIs. And it was compared to everolimus. You see about a 700-patient study. And these are the PFS on the left and OS on the right curves. This was at the second interim analysis, but almost identical to the first. You see identical median. So somewhat interestingly, these curves overlap till about 6 months, till about the median PFS. And then there's a clear benefit in that tail after 6 months to the patients receiving belzutifan, hazard ratio 0.74. No survival difference yet. This 0.88 was not significant. One may emerge late. It's a drug that doesn't act as early as TKIs. The responses tend to occur later, so it's a little bit of a delayed effect for whatever reason. So we may see some late benefit in the OS curve as we did in the PFS, but we should know within the next year. And it was FDA approved, I think it was December of last year. As I mentioned, it's a really well-tolerated drug. Anemia is the biggest side effect, easily treated with growth factors. So as you start to give this agent in your practice, the anemia is really not a big deal. It's easily treated with growth factors. You see some of the other side effects listed there. Hypoxia is not on here, but that is a sort of more rare but significant side effect, generally treated with dose interruption and reduction, and obviously ruling out other causes. But a very clean agent. Again, it's a transcription factor inhibitor, unlike our multi-targeted TKIs. Very clean toxicity profile. And I also started to use this a lot now in my refractory kidney cancer. And then this is just a slide I made for our Your Amigos meeting, looking, because these TiVo and Belzu are sort of very similar agents, not mechanistically, but similar, and really similar data. You see response rate similar, PFS identical, different comparators, but almost identical PFS hazard ratio, similar landmarks, et cetera. So I think both are options in the refractory kidney cancer space. I use them a lot, and I use them interchangeably, and we can talk about how to choose one or the other. And I think that's it. So it's like all of kidney cancer in 15 minutes. So frontline is an IO-based doublet. We talked about some of the nuances of selection. Don't forget about observation and local therapy. And then in refractory kidney cancer, you should not be using sequential immune therapy, in my opinion. And then there's a number of non-curative options. And again, it's like frontline. It's familiarity with the drug, having sort of an algorithm that you use. There is no right or wrong, in my opinion, but there are an emerging number of options, including belzutifan and tivozanib.
So, Eric, a couple questions about belzutifan. First, is it being looked at in combination with anything, particularly IO? Also, can you be more granular or specific about exactly what kind of situations right now you would use it outside a trial setting?
Yeah, so answer the second question first. In an individual who has progressed on upfront IO, or IO-TKI, and then if they've then received a second-line TKI, so they've experienced IO and they've experienced TKI, I think this agent certainly can be considered. And if you look at the third line versus the second line in the trial, the hazard ratio there actually was good for both groups. So this is, I think, something you can consider. It's well tolerated, got great toxicity profile, and there's a subset that benefit.
And do you actually see objective responses?
Yes, so the objective response rate in the study was 22%, but what you do see is you see that a majority of individuals will have some shrinkage of disease. The fly in the ointment with the data is that you have 34% of people who have upfront PD on the phase 3 study, but because the drug is relatively well tolerated, you repeat scans. If you see they're not benefiting, you move on to something else.
Interesting. Mayan, again, any questions? Again, you were mentioning to me you were curious about the issue of oligometastatic disease. Anything you want to ask him about that?
I mean, I think you did mention that if you have small lesions along you, that might help to resect those lesions with oligometastatic disease.
I mean, I generally do SBRT, not resection. I think
okay.
the really difficult part for me is you can get caught in this, well, I'm just going to radiate things to radiate them, right?
Yeah.
And radiating small asymptomatic lesions, I'm not sure is helping patients. So one thing I think SBRT has a role in advanced kidney cancer. Exactly how big that is, I'm not sure. It's easier if there's a solitary progressing lesion. Okay,
Right.
that's
or
easier.
liver lesion, like one spot in the liver.
Yeah, or if you can radiate everything, that's easier. But there's a lot of gray area, and it's I think sort of evolving.
Right.
Eric, any comment about oligometastatic disease, particularly in the setting of IO, I mean?
Yeah, no, I think that clearly individuals that have oligometastatic disease have declared their biology. The interesting question is we don't know whether resection of those lesions actually prolongs their survival or not, but it certainly does provide it's usually possible, and with these new techniques like SBRT, I think ablating them is a reasonable thing. I don't think we're going to ever have a trial that's going to demonstrate that this provides an overall survival advantage, but I think it's a reasonable management strategy, which then decreases the need for systemic therapy, at least for the interim for these patients.
So, Brian, I don't know whether you would agree that maybe there's been a little bit of a plateau in research developments in renal cell, at least from the clinical point of view. I would say that kind of seems that way to us. Anything, and anything sort of moving forward that you're excited about in terms of next generation of therapy? It kind of seems like we're maxing out on IOs and TKIs. Belzutifan is certainly very interesting. Any other strategies out there?
I take that as a personal insult now. I don't disagree. I mean, we need new mechanisms in kidney cancer, and belzutifan is a new mechanism, but related. But I think, it's the newest, and I think to your earlier question, it is being studied in adjuvant, frontline, second-line combination. So Merck sort of just put it in the water everywhere in kidney cancer.
Plus IO also?
Plus IO, yeah, all of them. So we'll see, not all of them, but we'll see in the next coming years. And I think it will find a home earlier in combination and not as monotherapy. But we need new mechanisms. There have been some CAR-T approaches that haven't really gone anywhere, but new immunomodulators, be it CAR-T or BiTEs or other cell therapy we need. But I agree, we're just stacking agents now. We have a lot of agents, but we need something transformative. I don't know what that's going to be, but I agree we need it.
Would you do genomic testing for kidney cancer?
I do genomic testing, I would say sporadically in a refractory sense. Having done it over many, many years, it's a rare patient where it's helpful.
That you find something.
Non-clear cell, which Eric's going to talk about, I tend to do it more. I'll do it as that patient approaches third or fourth line because I might have a trial.
To find something, right.
I'm hoping against hope, but I warn the patient that the chance of it impacting their care is pretty small.
Right. Again, Eric, any thoughts?
Yeah, I think what we have is a strategic challenge. So industry-sponsored studies have performed clinical endpoints. We don't have the biological endpoints really built into it. So we kind of have to go back to school at this point in time, and we have to design trials where we're actually gathering information, where we're gaining knowledge that allows us to understand why people are responding or not responding. We haven't done a good enough job on that as we should. And part of what we're doing, Brian and I are involved in the Kidney Cancer Research Consortium, which is this multi-center consortium in the US, where we're making sure that the trials we do are tissue-rich, where we have analytical tools that are embedded into it. So we're basically doing science with research, with clinical research. And I think that's what we need.
Interesting. Let's talk about this patient, a 65-year-old lady. What happened with her?
Yeah, so this 65-year-old woman, past history of GERD, she was found because of her workup for GERD to have a renal mass, and this she underwent resection of this. Turned turned out to be actually reasonably aggressive, Fuhrman grade 4, some extracapsular extension, some degree of renal vein invasion. And the patient comes into the office, and after the nephrectomy, and you have a conversation with the patient about, so, what's your likelihood of recurrence at 2 years and at 5 years? I think our nomograms, so there are several nomograms that you can get online. There's the Assure nomogram, which is available on the Fox Chase website, which used the data from a large randomized study that was done multiple years ago, the control group. And the data there, I think, at 2 years in terms of the probability of recurrence or relapse is relatively robust. And you put her data in there, and you see that she's got about a 1/3 chance of this disease coming back. So you have a discussion with the patient at this point in time about what to do next, and are there any reasonable options from an adjuvant therapy perspective. And the data from Keynote 564, which is a study that looked at randomizing individuals between a year of pembrolizumab versus a year of placebo, now do have overall survival advantage data and also progression-free survival or disease-free survival data. So this is, I think, a patient where that conversation is, I think, really important and relevant.
How strongly would you encourage a patient in this situation to receive treatment? And if, maybe the patient is a doc and can really understand some, more sophisticated information, if they said, well, how's that going to affect the 35%?
Right. Yeah, so what we have is we have a hazard ratio. The DFS hazard ratio has hovered between the low 6.6 to low 0.7s. So you basically have a 1/3 risk reduction at 2 years of relapse with this regimen. Countering that is the fact that you probably have, and this is a kind of a calculation, my sort of number is about a 5% risk of having what I would call life-changing toxicity from pembrolizumab, like type 1 diabetes, like chronic rheumatologic problems. And so you then look at what's your risk reduction here, 1/3 of 35, you've got 12-ish% at 2 years, and then 5-ish% of serious toxicities. And discuss that with the patient to see whether or not this is a choice they want to make. I have some patients who, I'm taking care of my wife with Alzheimer's or husband with Alzheimer's. I really can't afford to be sick. And those individuals may say no. But here I would say that objectively the data would suggest that this is a reasonable choice for her.
So Mayan general medical oncologists deal with adjuvant therapy all the time, the challenging situation of treating some people. You're treating some people who are cured, which is challenging. They're getting exposed to the toxicity. You heard the numbers that kind of are in Eric's head. How do people respond in your practice to this kind of this setup?
I feel like people want to live. So most patients want anything that helps them go longer and not worry about the disease recurrence. And again, it depends on the age too. Like younger patients, of course, they want to take any opportunity to survive longer. Maybe someone in their late 70s, 80s, those are the patients that, might be hesitant to be on therapy. I do the discussion and I go through the percentages and what toxicity you would expect. I feel like our nursing staff is very comfortable managing and detecting toxicity early stage, and we can reverse those. So I feel comfortable recommending immune therapy to those patients. There are patients who don't want to do anything, but most patients really want to look for options and want to make sure they don't have to deal with this anymore.
All right, Eric, let's take a look at the data, and we're going to start out here with adjuvant data.
Great. Yeah, so here's the design of the study. Just shy of 1,000 patients that were randomized, as I mentioned, between pembrolizumab and placebo. Primary endpoint was disease-free survival by investigator, and there was the usual, and importantly also, what kind of patients were in this. So it was T2 high grade, grade 4, was the basically lowest grade, and then T3s, T4s, as well as resected M1s who were resected within 1 year of diagnosis were also included in this. And here's the disposition of the patients. Here are the baseline characteristics, very typical, early 60s, and a fraction of these, about 5.6%, was in this M1 group. Here are the Kaplan-Meier curves for the overall survival, and this was just presented. So you can see there's a nice separation of curves here for an OS perspective as well. And a lot of people in the field were saying, well, we're waiting for the OS. If the OS is positive, we're going to give this. The thing about it is the directionality of the OS curves prior to this presentation were already there. So it's a choice whether you say that a p-value of 0.02 versus 0.01 is significant or not significant. So this didn't change anything for me that that much, but I think it does provide confidence for the community that this is providing an overall survival. By subgroups as well, here overall survival, you can see, there's these weird things that happen here, like for example, females versus males. I don't know what to make of that. This could be a statistical fluke, but by and large, if you look down across the various parameters that are looked at here in this forest plot, you see that there's a directionality in favor of pembrolizumab. Here are the PFS data that were updated, hazard ratio here 0.72. It's popped between 0.68 down to 0.63, now to 0.72. I think, a third is roughly what we're dealing with here. And DFS by subgroup, once again, was fairly consistent here. You do see that in that M1 group, that although it's a small group, you see that directionality both in the DFS as well as in the OS was favoring that group. So that's basically the data we have now. There are other agents, for example, sunitinib in the adjuvant setting, which did have a DFS advantage compared to placebo, but we don't really use that much combination toxicity, lack of overall survival, and that wouldn't really be an option. But this is, I think, a reasonable choice to have a discussion with your patient. So let's move on to non-clear cell renal cell carcinoma. So this has definitely been this is a very heterogeneous group biologically. Okay, we have papillary, we have chromophobe, we have collecting duct, we have medullary. So it's been a little bit challenging because they're rare and they're more heterogeneous to come up with reasonable choices. This was a study that was run by Monty Paul and Swag. 4 arms initially, randomization of agents that basically were hitting MET in some way, shape, or form, because MET upregulation occurs in papillary. And this was then shrunk down to 2 arms. And in this particular study, we did see ultimately that in these papillary renal cell carcinoma patients, that cabozantinib had a longer PFS compared to sunitinib. Modest numbers, but I think one that would be sufficient to push you in favor of cabo over sunitinib. In terms of non-clear cell in general, we have, again, larger data sets, some randomized, some non-randomized, looking at things like, for example, pembrolizumab monotherapy. And this was the Keynote 427 study where there was a reasonably sized 165 patient arm of non-clear cell renal cell carcinoma, asking the question of whether this therapy in the frontline setting was useful. And what we saw here is an objective response rate which was in the mid 20% range, so not bad. And if you then look at the waterfall plot on the right, it's a bit small, but you can see that those are broken down between papillary, chromophobe, and unclassified. And you can see that definitely in the papillaries there was a subgroup that did have shrinkage. Even some chromophobes had shrinkage. But the data here, and it's not highlighted, PD as best response was actually 36%. So there's about a third of patients here that get 0 benefit. We don't know who these patients are, but monotherapy, I think, in this situation is something you could think about. There are some better data, actually, in terms of, perhaps, a belt and suspenders approach here. Non-clear cell renal cell carcinoma treated with lenvatinib and pembrolizumab. Again, this was a single arm study, large, about 158 patients. And the waterfall plots on the left here are broken down between papillary, unclassified, chromophobe, and then translocation. And you can see here that each of these subgroups do have some degree of shrinkage. The objective response rate in this study is about 50%. The progression-free survival was also very reasonable. The PD as best response was 11%. So this is certainly an option that could be considered for individuals with non-clear cell renal cell carcinoma in general. Here are the progression-free survival curves, again, broken down by these molecular subgroups. The OS curves, again, there's really nothing between them. And it's an option, I think, for these patients. Additionally, there are data, this is once again single-arm data, cabozantinib plus nivolumab in non-clear cell renal cell carcinoma, Cabo 40, Nivo, IV every 4 weeks, primary endpoint, objective response rate by RECIST. And what was interesting here was that they had a papillary and then they also had a chromophobe group. The chromophobe group, there were no objective responses. They ended up stopping accruing to that. We do see here the papillary translocation and unclassified group. Nice waterfall plots. So once again, I think this combination, this doublet, is something to consider. The shortcoming again is we don't have randomized data here, but they're good data. The progression-free survival, once again, about a year. And here are the progression-free survival curves and the overall survival curves. In terms of up-and-coming studies, there is the Stellar 304 study where zanzalintinib, which is what I would call a son of cabozantinib, is being tested together with nivolumab versus sunitinib, and these data will mature in the next year or so, and we'll see whether or not this is reasonable. At least it's a randomized study. I don't like the comparator arm. VHL in the last minute and 28 seconds here. So, we've really been amazed by what belzutifan has done. So this is a registrational study that I led that was published a couple of years ago and resulted in the approval of belzutifan in von Hippel-Lindau disease. Single-arm study, 61 patients, primary endpoint, objective response rate in the kidney tumors as well. But as VHL patients go, the majority of them had either pancreatic and or CNS lesions as well. And what we saw, this is now updated, these are updated data, this is getting better with time. So the objective response rates started off in the high 40% range, they're now 64% in the renal lesions. You see the waterfall plot on the right, there really were no individuals who had PD as best response. We saw also, and this is the update of the slide that Brian showed, that figure on the right, the number of interventions individuals have had post-initiation of belzutifan is not as small as it was before, but it still remains considerably lower than prior to initiation of therapy. So we're really, for these patients, what matters is that they don't have another surgery, and we're helping that happen for a subset of these patients. Amazingly as well, for the first time in VHL history, we also saw shrinkage of hemangioblastomas on the left and pancreatic neuroendocrine tumors. We're working on getting like every single one of those bars to get down to 100% here, but it's pretty close. We're seeing amazing objective response rates of greater than 90% in pancreatic neuroendocrine tumors. The AEs, as mentioned before, anemia. In a younger patient population, hypoxemia a little bit less of an issue, and fatigue. And treatment discontinuation was relatively rare. Here are these adverse events once again in tabular form. And that's the end of my slides.
What a fascinating and amazing story also. So we're going to move on now, but thank you so much.